And you'll be hearing from 4 dynamic speakers today. Before I get to the introductions and get us into the webinar, a few housekeeping issues. All of the folks attending will be in listen-only mode until we get to questions and answers, which will be at the end of our 4 speakers. So please do hold on to your questions. Also feel free to type a question into the message box, and we will make sure to get to your question when we have time at the end. Please note that the slides in this presentation will be sent out to you afterward. It will be recorded, and both the recording and the slides will be sent out to the list of attendees, and will also be on the NVHR website. So we have a limit of 100 folks today, which will be meeting in a little while. So if you know folks that cannot join us today, please know they will have access to the recorded slides and slides themselves after the webinar. So again, welcome to the Navigating Hepatitis C, What Patients Need to Know. Before I introduce our first speaker, I just want to remind you that NVHR is a broad coalition working to fight and ultimately end the hepatitis B and C epidemics. We encourage you, if you're not already a member, to please go to nvhr.org to join us to help fight the hepatitis B and C epidemics. But today, we have a really special panel to share their experience in talking about navigating hepatitis C. We're going to look from the screening angle, accessing care, getting treatment, and living with hepatitis C. One thing that's really dynamic about all 4 of our speakers is that they're able to speak from both the patient and the provider perspective. All 4 of our speakers today were living with hepatitis C and are now cured. You may hear a little bit about their story as we move forward. Our very first speaker is Bruce Burkett. He's going to talk about screening. He's the founder and director of the Hep C Alliance since 1999. He survived 5 rounds of interferon-based treatment before being cured in 1999. The Hep C Alliance provides free testing for hepatitis C and education in Missouri and parts of Kansas. And so please welcome Bruce, who again will be talking about hepatitis C screening. Welcome, Bruce.
Thank you, Heather, and welcome everybody. I appreciate being here to help present this program. You change slides for me, please. Hepatitis C is one of those innocuous diseases that we don't know who all has them. We've got these standard people that you're supposed to look at and screen if you've ever injected illegal drugs. The new number, which is the baby boomers, anybody born between 1945 and 1965. In fact, they look at screening as so important, it's counted as a preventative health measure. And if you do have health insurance, there is no copayment or deductible associated with getting that test. Anybody that is infected with HIV should be tested. We do actually have about 20 to 30% of the people with HIV in the United States are co-infected. And as with the rest of us with Hep C, many of us aren't aware of it yet. If you have symptoms of hepatitis C, which would be jaundice or elevated liver enzymes, that would be a clue for your doctor to go ahead and recommend you get tested. Now, a lot of people assume that it's drug users that get Hep C. But anyone who received a blood transfusion or blood products before July of 1992, there's a 10 to 15% risk they acquired hepatitis C from that blood transfusion. And for people who received clotting factors before 1987, that was also a risk factor. And when we talk about blood products, something a lot of women don't realize, but if their blood type is Rh negative, like A negative or O negative, when they're pregnant, they get a shot called Rogam. And before 1987, the Rogam was contaminated with Hep C. So if you've ever had that procedure, you do need to get tested. The other avenues you're looking at would be healthcare workers, nurses, housekeepers that might get a needle stick while working in the hospital, our firefighters, our first responders. You never know when they're going to contact with a blood exposure. If you've ever been on dialysis, and the kidney dialysis, if it's done, everything is done properly, there's no risk, but there can be mistakes made. So they recommend, if you're on dialysis, to get screened every 6 months. Now, if a woman has hepatitis C and she has children, there is about a 2 to 5% chance it will transfer to the children, but you cannot test that child until the child is between 12 and 18 months old. Tattoos and body piercings, most of the salons now are very safe, but if you got one a few years ago, or if you got one in prison, or even today by a homemade tattoo artist, that is a risk for connecting with the virus, and you should get tested. Next slide, please. We have a lot of other groups that don't fit those great categories, but you look at a lot of low-income communities, people who have been homeless, people who have been incarcerated greater than 6 months. Those are all areas that you can find groups of people that are likely to be infected but need to be tested. If mental health conditions or if there are any type of substance use, again, that is a sign to get tested. African American ethnicities, and we're also looking at other groups like the Hispanics, other immigrants from other countries, have a possibility that they have been infected in their home country and are bringing it here, so they need to get screened as well. And then if you have a group that is just overrepresented by all these risk factors, as a group, they should get tested. Next slide, please. Now, Hep C testing, it's kind of an alphabet. The first test you do would be the Hep C antibody, which is simply going to tell us if you've been exposed to the virus or not. Then you have an HCV RNA quant, which is also called a viral load, or the RNA qualitative, which it says yes or no. The genotype is a test that's important to determine which treatment you should take, and that'll be covered in a later session. And then what fibrosis you have. Next stage, please. Okay. The antibody test says that the antibodies have been formed in your system, and that probably came about in over the last 3 months or before the last 3 months. I'm looking at my wrong slide. I apologize. The non-reactive means that as of 3 months ago, you had not been exposed to the virus, because it does have that window period. So if you get that test and it's non-reactive and you have not had a blood exposure in the last 3 months or to 6 months, then you're good to go. You don't have to worry about it unless you get re-exposed. Next slide, please. The reactive antibody only says that you were exposed. It doesn't tell if you have active infection or chronic infection, if you had it before and have been cured. Like for myself, I've been cured since 1999, but I still have a reactive antibody. So once you've been screened with a reactive antibody, that test never needs to be repeated. An interesting number is between 20 and 40% of the people that get exposed to hepatitis C will actually cure themselves. And for some reason, we do see a larger number of young Caucasian women tend to clear the virus more than any other group. Next slide, please. Now, fibrosis. Your liver is the only organ in your body that will actually regenerate itself. But when you get infected with the virus, it's going into a liver cell and destroying the liver cells and making copies. Kind of imagine if you cut your hand, it's going to bleed a little bit, it'll heal up, and you can't tell where you got. That's kind of like stage F0. You've been insulted, but there's no damage done. Now, if you keep cutting your hand over and over and over, now you're going to get a scar, and that scar is actually, you now have cirrhosis. And that scar means that your liver is so scarred up that it's not functioning properly. And to figure out which stage you're in, whether it's 0 or stage 4, that requires either having a liver biopsy, which is where they'll actually take a small sample of your liver to judge how much damage has been done. And that's actually the gold standard. Recently, they started using a test called the FibroSure, and then I believe it was last year the FibroScan was approved in the United States. And that's kind of like an ultrasound, but it's using waves to measure the stiffness of your liver. And it's a good way to access how much damage has been done. Next slide, please. Okay, the genotypes, there's 7 of them worldwide. Genotype 7 was only found last September, so it's very, very new. In the United States, most of us have genotype 1, either 1A or 1B, but we do see genotypes 2 and 3, and they actually need to be treated differently. Next slide, please. Okay, your HCV antibody, if it's non-reactive, that means you've not been exposed in the last 6 months. If your antibody is reactive, you have the RNA test, and if that's not detected, that means you either cured yourself or you have been cured by medications. Now, if it comes back and says it's reactive and the RNA is detected, and that number, if it's a quantitative, could be anywhere from 15 international units over 50 million international units. And all that number means is you've got active hepatitis C. It doesn't say how much damage or how long, but it says that you've got it. And next slide, please. And one more. Okay, now I'd like to turn this over to Robin. I am unfortunately at a meeting, so I won't be available for questions right after this. But if you post any questions, they can get them to me, and I will reply to your questions. Thank you very much, and Robin, I believe, is next.
Okay, thank you very much, Bruce. So our next speaker is Robin Lord-Smith. She's going to talk about the access to care for hepatitis C. Robin Lord-Smith is a peer counselor and operations manager for HEP, a national helpline for people affected by hepatitis C. She has been cured of hepatitis C for over 10 years, and she is the vice president of the Hepatitis C Association and co-chair of the Maryland Hepatitis Coalition. So welcome, Robin Lord-Smith.
Hi, thanks, Heather, and welcome to everyone. I'm so glad you could join us today. What I'm going to cover basically is access to care, and by that we mean being able, you've got your testing done, and now you need to see a specialist, okay? And a lot of folks that call us, for instance, a lot of things I'll say refer to the work I do with the helpline because that's something I do every day. We take calls from people all over the country at different levels and different places in navigating, addressing their hepatitis C. A lot of folks we call do have insurance, and if you have insurance, you know, who you're going to be able to see as a provider is definitely going to be determined by whatever plan you have. We do on the helpline have a list of referrals of specialists around the country where you're going to have to work with your primary care provider and your insurance to determine a specialist in your area. There, you are going to want to not be shy and assure that the provider you've been referred to does see people regularly for hepatitis C, stays on top of the latest guidelines, and all the great innovations that have been made in medication. So I guess these are some of the topics I'm going to cover real quickly, and we'll start with the next slide, testing. Bruce already did talk about the testing and the details, but some people don't know where to start. Some people may not have access to care or a primary care doctor. And the things I have listed on this slide are different things that we explore in terms of, you know, how do I get started even with an antibody test? A lot of local health departments do have access to antibody tests, not all. Your mileage may vary, and you're going to have to call and check it out. There are some resources that we have on the helpline and some other resources listed here. A lot of times HIV testing programs have also added hepatitis C testing, so we look at those resources. We do have national testing days, and a lot of states during Hepatitis Awareness Month in May do testing days. That's a resource we can look at. Bruce's program, Hep C Alliance, also has a new program where you may be able to access testing in a more affordable way if you are uninsured. So that's a good resource that we look into. Caring Ambassadors program at hepcchallenge.org has a testing locator. Personal Labs is a program with LabCorp. We actually do some education and referral sometimes to use that as a way to access antibody testing, confirmatory testing, the RNA tests that Bruce talked about, genotype testing, without having to go through a physician. And sometimes if there's a limited income situation and you can't find other resources for testing, you may be able to access that in your state. And as I said before, at Help for HEP, we do have testing site referrals. Another good location for testing can be a federally qualified health center or other community clinics. And again, your mileage may vary in terms of whether or not they can, once they've done an antibody test, being able to do a follow-up confirmatory test. But you're basically going to have to take it one step at a time. Home test kits are also out there, and there are other community clinics. There are a couple of resources for looking at community clinics, and these are all things that we go through with each caller that calls into the helpline. Next slide. Next slide. Okay, thanks. Now, insurance. I talked about a lot of folks do have insurance, and they can go through that process to identify a specialist for further assessment and care. There are a lot of folks that don't have insurance in the United States today. When people call on the helpline, one of the first things if they're uninsured is that we want to determine is, are they eligible for Medicaid? We may help them look at the state Medicaid guidelines, find a contact number for how to look at their Medicaid program. Also, we always check the Medicaid expansion status. About half of the states have taken in the expansion, and more people are eligible for Medicaid than realize it a lot of times. The Affordable Care Act can be an option for getting into insurance, and actually get quite a few calls from people who haven't looked into that. There's currently an extension period through, I believe it's April 14th. I'm sorry, I think we can provide that with the extra information that we send out and be sure people know about that. There are some situations where some people still may be eligible to enroll, I believe, by April 14th. And also sometimes people don't realize if they've had a change in their financial or insurance status, they may still be able to enroll via healthcare.gov and get insurance through the Affordable Care Act. Patient Advocate Foundation is an organization that's been out there doing case management for a long time. They have started a hepatitis C care line where they're doing a lot of things to help people with hepatitis C in terms of identifying other community resources, other funding sources, perhaps to help with access to getting in to see a specialist. Also help a lot with people that are having challenges with access to care and access to treatment, maybe going through denials with their insurance and going through the appeal process. I think Lucinda's going to talk a little bit more about that. The Hepatitis Education Project for people in the Pacific Northwest, they have a hepatitis C case management program where they're specifically helping people in that part of the country have access to care. And there are other case management options for looking for insurance. Some people have a case manager perhaps through a mental health provider. I think that's about it for this slide. Yeah, next slide. Now, we also look at local provider resources. The Federally Qualified Health Centers, or FQHCs, some of them are going to have community partners that have specialty care, that have infectious disease doctors, gastroenterologists, hepatologists, and some aren't. Those are the things that we look at. And honestly, a lot of times if we get calls in from the helpline that are uninsured and aren't really in care, we do encourage them to contact a local FQHC or a free and low-cost clinic to begin primary care, so they can start with their primary care as we explore options for specialty care. Needy Meds is another great resource on the internet that can help you find some of those free and low-cost clinics. The local 211 is usually run by United Way or another community organization, and confidential referrals to local care. Sometimes there are programs in counties that we don't know about. It's always good to check with 211 about any kind of assistance that might be available. There also, we have, as I said before, we have a list of providers based on county, state, zip code that we can look at. And I've actually known quite a few people that have been able to make payment plans, and by making payment plans, negotiating care, been able to get access to medications and are good today. We also look at university hospitals in the area, gastroenterology, liver clinics. A lot of times the transplants have liver clinics that see people that don't necessarily need to be evaluated for a transplant at this point. A lot of the nonprofit hospitals have physician groups that you may be able to access care with a financial assistance application. Local hospitals often have medical social workers you may be able to access, especially if you've already been there in care, but that's a good resource to check for what local providers may have some pro bono or some sliding scale slots available to see a specialist. Another thing some people forget sometimes is if they have access to medical care through the Veterans Administration, that can be a great resource. There are other state providers that we've identified and continue to identify. A couple of examples would be the Grady Liver Clinic, which is associated with Emory University in Atlanta. They have a financial assistance process. The Frederick, I'm in Maryland, the Frederick Hepatitis C Clinic in Frederick, Maryland, will see anyone. If you're uninsured, last I checked, it was still a $40 per visit copay. You can get a complete assessment, and they help people with financial assistance applications for accessing medications. So as you can see, there are a lot of ideas here. I know this may be a little overwhelming. And on Helpline, we listen carefully to try and see what some of the best options might be for someone based on where they are and what the situation are. But there are a lot of possibilities out there. Next slide. Oh, another couple of points. I put Help for HEP at the top because that's what I do and that's what we do. We try to help people negotiate care. Once you have your doctor, you may need assistance with accessing labs. Okay, oftentimes you can apply for financial assistance at your local hospital again to have more affordable access to labs and diagnostics. A lot of the laboratories themselves actually have financial assistance applications. Many people don't realize this. Always, always ask. The same is true with the university hospitals and liver clinics, the nonprofit hospital physician groups. Sometimes it can be as simple as calling the finance office, the financial assistance office, and asking for an application for financial assistance to make an appointment with one of their providers. Next slide. I know that we have a lot of different types of people on the call today. We have patients, we have advocates, we have people that are providing services for people affected by hepatitis C. So I created this slide just to give an idea of some of the different community partners you can begin working on when you're developing resources in the community. And we actually get a lot of calls on the helpline from people in communities that don't have strong systems of support. And these are some of the things that we suggest in terms of places to reach out to start to build that network, the gastroenterological groups, the digestive disease groups, infectious disease groups, the HIV programs, community hospitals, oftentimes are looking for other people to work with them to broaden the network because they're aware that this is an epidemic and they need to do more organizing. Medical school clinics can be a great resource for too. And I always remind people to reach out to their state viral hepatitis prevention coordinators because there may be other programs in their state they're not aware of or something that's being developed. So I think if we look at this last slide, it's just a reminder that there are a lot of different types of patient assistance programs out there. And I'm hoping by giving you an idea today of what some of the resources are, that it gives you a sense of promise and hope that there may be an alternative, especially if you're someone that is currently uninsured and having difficulty accessing care or finding someone to treat them for their hepatitis C. The pharmaceutical manufacturers have patient assistance programs. There are some foundations that have copay and financial assistance programs, and all that information is going to be provided along with the slides and the recording after our presentation today. So I think that's about it for me. I hope this was helpful and look forward to answering any questions you might have. Thank you.
Thank you so much, Robin. Thank you for going over those wonderful resources. I think all of us that have been doing this for 10 years or more, it's amazing how many resources there are today compared to a decade ago. Our next speaker is Lucinda Porter, RN, and she's going to be talking about treatment. She's the author of Free from Hepatitis C and Hepatitis C One Step at a Time. She's a longtime HCV advocate contributor and also contributing editor for Hep magazine. Lucinda went through 3 rounds of hepatitis C treatment herself and is now cured. She blogs at hepmag.com and also lucindaporterrn.com. Please welcome Lucinda Porter talking about hepatitis C treatment, getting it, paying for it, and doing it. Welcome, Lucinda.
Thank you, Heather. Welcome to everyone who's listening, and thank you for the folks at NVHR as well as to my fellow panelists. I have a rather large subject, which is hepatitis C treatment, getting it, paying for it, and doing it. So I am just going to jump in, and I'm going to talk really quickly. So if I go to the first slide, please. Oh, there it is. Okay, so now I'm not going to be able to go into the nuances of which treatment is for which, say, genotype or if it's a retreatment. What I really want to do is provide you with resources so that you know where to find that information. Personally, my go-to site is the hcvguidelines.org. They are fantastic. Now, for those of you who want something maybe even shorter, if you go to hepmag.com, you will see under hepatitis C, they have an index of information, and there is a table there that lists everything, and it's pretty helpful. It's the quick and easy way of finding that information. But basically what I want you to know is that right now we are in an unprecedented time in terms of hepatitis C treatment because we have lots of medications. We have Harvoni and Alisio and Sovaldi and the Curapac, as well as the old medications, PEG interferon and ribavirin, which may be used in certain circumstances. Now, all of these are used in combination. Well, sometimes Harvoni is used alone, but the number of possibilities is exponentially growing. But what we have, bottom line, is that hepatitis C treatment is significantly easier. It's shorter and it's effective. We're able to cure just about everyone. But behind that is an amazing amount of fear in the Hep C community that patients are still reluctant to undergo treatment because they're afraid of side effects. You know, we thought it was hard to confront the side effects with PEG interferon and ribavirin, but now we have treatment that's much easier, and we have to get that word out, because if you just open up and read the side effects listed in the patient information, it can be daunting. So let's move on to the next slide. So basically, we have a new approach. In the old days, we would treat the acute hepatitis C infection that's less than 6 months. We would treat it differently than chronic hepatitis C. But now what we do is we wait until if a patient might have cured on their own. We call that a spontaneous clearance. And in some cases, up to 50% of people may spontaneously clear. So we let them go ahead and see what their body will do naturally, and if they remain infected, then we'll treat them as a chronic infection. Next slide. So how do you decide which of those drugs and for how long? Well, there are medical factors and non-medical factors. The medical factors are whether someone's been treated before, what their genotype is, how much liver damage do they have? Do they have cirrhosis? What's their viral load? And do they have any other medical conditions? Now, the next slide talks about non-medical factors. And the reality is that cost is driving treatment decisions. These medications are very expensive. And the people who are paying for the medications, the insurance companies and Medicaid programs, are putting their opinions into the treatment decisions. And I think this is wrong, and I'm here to promote ways that we're going to try to fight this. So the non-medical factors are going to be insurance coverage, your ability to pay, and whether or not you're using substances. For the first time in a very visible way, this is sort of what's going on before, but now in a more visible way, we are seeing people who are required to go through a tox screen to see if they use drugs or alcohol, and this includes marijuana use, and that it come up with a positive tox screen and you will be denied treatment in certain circumstances. Next slide. So now what I want you to know is I'm sort of reversing this, that these non-medical factors that are influencing decisions are largely because the American Association for the Study of Liver Diseases and the Infectious Diseases Society, when they came up with the HCV guidelines, they said who really needed priority. Who should have the highest priority, who should be treated immediately. And behind that are the insurance companies sort of saying, oh, okay, let's deny treatment to somebody with earlier stage of liver disease, and let's get these priority patients treated. But let's see what the truth is. So the next slide says what the truth is, and this is featured prominently on the HCV guidelines. Evidence clearly supports treatment in all HCV-infected persons. And the exception to this is somebody who might die within a year of an unrelated condition. Let's say somebody has breast cancer and they don't have a good prognosis, then hepatitis C treatment might not be a high priority for them. So they're not recommending treatment for them. So what I really want you to hear is that patients and providers should be driving the treatment choices, not the insurance payers. And this is the proof that all of us have some benefit if we choose to be treated. Next slide. So how do you advocate for that? What I want you to do is focus on the goal. Treatment is cost-effective and it's potentially life-saving. We die an average of 15 years younger than the average person of other diseases, not just liver diseases. So we have to focus on the goal of getting treatment if we want it. Ask your doctor to be your advocate. In fact, expect your doctor to be your advocate. And if your doctor isn't, then maybe it's time to have a heart-to-heart conversation or move on. Stress your symptoms. Write them down. Bring a buddy along with you. Don't go into your appointment when your doctor says, how are you feeling? You say, fine. Don't say that. Say, I'm tired. I'm achy. I can't think straight. Get support. The resources in the end will show you what some places you can get some support. Make sure you can pass that drug and alcohol screening, and expect denials, and expect to appeal, but don't lose your patience and don't lose hope. Next slide. And don't give up. Don't give up even if your provider doesn't want you to treat, or if your insurance won't cover it, or if you think you're going to be denied because you don't have advanced liver disease. If you don't have insurance, you can still get treatment. There are ways to get treatment. And even if your income is high and you don't think you're going to qualify, don't give up. Try for treatment. Next slide. So once you get approved for treatment, how do you manage it? Well, first of all, make sure that you stay clear of drugs or supplements that might interact with the hepatitis C drugs. So talk to your provider about everything you take, over-the-counter, prescribed dietary supplements, herbs, etc. Second of all, learn how to manage the side effects. Early intervention is best, and my go-to place for learning how to manage side effects is the HCV Advocate website. There are fact sheets there for everything from fatigue to rashes to dry mouth. And then get support. Get support. I think that should be number one on the list here. And my go-to place for that are the forums at HepMag. HepMag magazine has other ways of supporting hepatitis patients. I would highly recommend you check out their website because there's the latest information, and there are blogs, and there are the stories, etc. But the main thing is that you really want to make sure that you're going to finish your treatment. Okay, next slide. Now, probably one of the best places to find all of the resources right now, I think, is on the NVHR website. Their baby boomer resources are fantastic. In fact, all their resources are. That site is just phenomenal. Additionally, make sure you know how to find out what the treatment choices are, and again, the guidelines are the place to find out what the latest treatment recommendations are. And if you want some help, I memorize 877 Help for Hep, because this organization, you know, Robin and Bruce work for them, and they're just fantastic. And then if you can't get treatment, consider a clinical trial. That's how I got cured. I couldn't afford the treatment. This was at a time when triple therapy was available. I just couldn't wait, and I went to a clinical trial, and I got what was the equivalent now of Harvoni. It didn't cost me a cent. And the last slide, I just want you to remember that we all deserve a cure. The world deserves to be cured of Hep C. The world would be so much better without it, and everyone has a right to be treated. And that's it for me, and I hope at the end to hear some questions. Thank you.
Thank you very much, Lucinda. Our last speaker today is Ronnie Marks, and she will be talking about living with hepatitis C. Ronnie is a patient, an advocate, and a facilitator of one of the longest-running HCV co-infection groups at the NYU Langone Medical Center, and founder and director of Hepatitis C Mentor and Support Group. So please welcome Ronnie Marks.
Thank you, Heather, and welcome. I am happy to be talking about living with hepatitis C, as when I got diagnosed in 1997, there was no information out there. There was no real internet. There were no support groups, and it was a really hard time. We've come a long way. I think that today, as a patient, a support group facilitator, and founder of HCMSG, which I formed to provide resources and supportive services to hospitals, clinics, and other organizations, I wait and speak to patients every day that are looking for how to live with hepatitis C. And as we have here, the first thing is to go to a medical provider or to a clinic that treats HCV. Remember, hepatitis C today is curable most of the time, and the new treatments are shorter and more tolerable. And as one who treated 3 times, both times in the beginning with interferon, I can tell you it is so much easier today that you almost wonder if you're even on medication some of the time because of the lack of side effects. There are many excellent websites that you can go to. Lucinda mentioned many of them, and I know there will be some more that will be on the presentation at the end. And support groups. I cannot say enough about support. You must have either a buddy or attend a support group either in person or many online, but make sure you have some sort of support. It's just absolutely necessary. Next slide, please. Transmission. Important to know how hepatitis C is transmitted. It is spread by blood-to-blood contact. If you'd had a blood transfusion or blood products before 1992, if you've shared needles all drug paraphernalia. You could be at risk and must be tested. Tattoos and body piercing, and don't forget about the dye. The dye is another way that one can get infected. Personal care salons. Go get your nails done. Make sure to bring your own equipment. Bring your own, whatever it is that they use. Make sure that you have your own because you do not know that it's sanitary. And the last, shared household items, razors, toothbrushes, anything blood to blood. Next slide, please. Next slide. Make lifestyle changes. There are things that one can do for themselves. Avoid alcohol and drugs. It's only going to exacerbate the virus. Make sure that you've been vaccinated with hepatitis A and B. Eat a healthy, balanced diet, vegetables, fruit, whatever it is. Stay away from fried foods, fatty foods, anything that can affect your liver. Remember, anything you put into your mouth goes through the liver. So just remember that anytime you're about to put something in your mouth. Exercise, important. Don't just lay around, get up and exercise. It's very good for you. You'll feel better. Be careful of Tylenol, herbs, and iron supplements. Be sure to ask your medical provider before you take anything. Don't listen to people, even though they may tell you that it's wonderful for you. Make sure to speak to your medical provider. And stress management. Do things that you enjoy. A walk in the park, a bubble bath, whatever it could be. It's a tough time for you, and make sure that you're doing things that bring you joy. Again, support systems. I cannot stress that enough. In person, online, friends, family, buddies, whatever it takes, make sure you have a support system. If you are experiencing extreme depression or having any suicidal thoughts, please, please ask for help. There are people out there that will help you. You even have the number of the helpline that was Lucinda talked about before, and Robin. Next slide, please. Once you are cured, do not just walk away and say, I'm cured, and forget about it. It is important that you have an MRI every 6 months, especially if you have cirrhosis. So please make sure that you get that done. If you are cured, remember, one can get reinfected, especially if you go back to the same lifestyle. I'm amazed how many people don't understand that they can get reinfected. Just because you're cured does not mean you cannot get hepatitis C again, and it will be harder for you the next time. Become an advocate, number one for yourself and then for others. Many people have asked what they can do to be involved. There are many different places also that will be listed. Become an advocate, go out and be the voice for everyone. And then live your life, mind, body, and spirit, and be happy. Thank you.
Okay, thank you very much, Ronnie. Well, it looks like our speakers got done enough time to have time for questions and answers from the rest of the audience. So if you have a question, you can type it in or raise your hand as well through the GoWebinar, and then we'll be able to unmute your phone, I believe, to ask the questions. Are there any questions for our presenters?
Karen Fox. This is Tina Broder, and I'll go ahead and share some of the questions that were typed in. The one question was how do the panelists feel about using family doctors to prescribe Harvoni and other new drugs rather than a specialist like a hepatologist?
Okay, maybe we'll start with Lucinda. So start with Lucinda and then have other folks chime in too.
I have mixed feelings about it. I believe that primary care and to a certain extent some of the other specialties really could, if they were well trained, could be able to do this, and if they really followed the guidelines. What concerns me is that if anyone steps outside of the guidelines, or if a patient has advanced disease, if they have cirrhosis, I think they really need to be referred to a liver specialist. One thing I want to stress is if you are working with a primary care or a non-specialist, or even if you're working with a specialist who's not informed, make sure that treatment is completed, because what we are seeing is people are having detectable virus at week 8 and treatment's being stopped. And when in fact we know that people can even have detectable virus at end of treatment and still go on and have a complete SBR. So just make sure you're working with somebody that really sticks to the guidelines, and you can see those guidelines on hcvguidelines.org.
Great, thanks, Lucinda. Any of our other panelists, Robin or Ronnie, want to add?
I agree. This is Ronnie. I agree with what Lucinda just said. It's so important that the doctor understands hepatitis C and these medications. So it's something that you really need to find out.
Okay, thank you. And a reminder that Bruce was not able to stay on for questions, but his email is on the screen. You can email him. Thank you.
I'll add something to that. This is Robin. I know in Maryland there's a program going on, and there are programs, I think there might be 1 or 2 more, where they're beginning to provide special training for primary care doctors in order to expand the number of providers that will be able to manage and care hepatitis C. I still think everyone should be assessed by a specialist, because those are the ones that are staying on top of all the latest developments. I think this is in our future, but I advocate for people doing the best they can to get someone that's the most well-informed on, as Lucinda was referring to, the HCV guidelines, and getting a thorough, up-to-date assessment on their current condition.
Thank you, Robin. Tina, do we have any more questions that have been submitted?
We have a lot of questions.
Okay.
To find a few, there were several questions of people asking about what they can do to improve their liver. One person had started treatment with Harvoni, but recently had a fiber scan, and the result was than they thought. So what can people do to improve their liver health?
This is Ronnie. Well, the first thing they can do is make sure that they're eating properly and taking care of themselves best that they can. As I mentioned before, be careful of what you're taking over the counter, and anything, again, that you're putting in your mouth, make sure that it's good for your body and liver. Refrain from drugs and alcohol, of course, as well.
This is Lucinda here. I always like what's good for the heart is good for the liver. When we look at a well-rounded health plan, we see the fundamentals of a low-fat, low animal protein, high vegetable, good sources of oils, exercise, lots of sleep, all of those things. What's good for the liver really is, if you're taking care of your entire body, your liver is likely to benefit.
Here's one little tip that I always share. This is Robin again. Just from the beginning, in terms of diet, start filling your cart from the outside aisles at the grocery store. If you think about it, most of the fresh food in a grocery store is going to be on the outside aisles. So if you can start focusing on filling as much of your diet up from those outside aisles, the fresh fruits, vegetables, the proteins that are available, and think carefully about anything that's processed.
Great, thank you. Next
Oh,
question,
I'm sorry.
Tina?
I did remember one thing I don't think we've mentioned. It is recommended that people with liver disease steer clear of raw and undercooked shellfish, because sometimes there can be a bacteria present there that can be dangerous for people with liver disease.
Great, thank you. Next question, Tina?
More questions, which is if somebody could explain what SVR means, and also if there are any contraindications to undergoing treatment.
My bad, I should know better. SVR means a sustained virologic response, and it's basically a viral cure. So if someone has hepatitis C and they succeed in getting through the treatment, and then the treatment is stopped, and and after 12 weeks or 24 weeks, depending on who you are working with, but I think 12 weeks is becoming more acceptable in most cases. If the virus doesn't come back in 12 weeks, you're considered having an SVR12, and that is effectively a cure. Now, one thing we just need to make sure people understand is that curing hepatitis C does not necessarily mean that you're cured of cirrhosis. And as Ronnie pointed out, make sure that you have follow-up for your cirrhosis, regardless of whether you're cured or not.
We had another question about how weight might affect treatment.
To my knowledge, these newer treatments that are not interferon-based are less affected by weight. But the problem we have, and we don't really have a lot of good data yet on weight, and particularly on if people have a condition known as fatty liver. But one thing about weight is that any of the medications that use ribavirin, then people will need a higher dose of ribavirin. And as someone who has taken ribavirin, it was very motivating for me to stay under the radar in terms of I did not want my dose to go up because ribavirin is a pretty tough drug to take. But again, the liver is not our only organ. You know, our body respond to our body prefers for us to be at a healthy weight.
We had another question, how do I go about starting a support group in my area?
Well, they can feel free to get in touch with me, and I'll be more than happy to help them and walk them through that. And if it's an area I'm going to be in, I could possibly help them with it.
That's you, Ronnie, yes?
My contact information is there.
We had a couple of questions about state medical restrictions, only authorizing treatment if there's a sign of advanced disease, and whether this might be true for commercial insurers as well. So could the panel speak to that any further?
Yes, as Lucinda here, we are seeing this, and it's just, to me, it's deplorable, and we are seeing this in commercial insurances. But I am seeing quite a bit of success in fighting this. I'll give you an example. I've had the hardest cases to get approval for have been some of the Kaiser-based organizations. And after trying to appeal decisions, patients are going right to their insurance commissioners and filing complaints, and they are winning approvals. So I would, again, even if you aren't approved, there are ways of getting the medications that go outside of the approval process. So I would work with the various organizations, particularly Help for Hep. They'll give you the resources for who are the patient advocacy organizations that are that might be suitable for you.
We also got a couple of questions related to Medicare, what the insurance considerations are there, and if people are having an easier time getting approval with Medicare.
Robin, do you want to answer one? Or do you want me to do that?
Oh, you can go ahead and do it. You're having as much experience with that as we are, probably. I think it's going to depend on the pharmacy benefit provider. I think it's still relatively early. We have to remember in terms of the number of people that are applying, getting on medication, and the feedback we're getting. I know that different manufacturers are negotiating different prices. And there are so many different policies, so it's going to depend upon who the provider is, who the payer is, and who the pharmacy manager is. Do you have more than that on that, Lucinda?
No, I think that one of the things that people do find, they get scared because they read about the copays and they hear, they may get approved, but they are concerned about the copays because Medicare can't negotiate the way some of the private insurers can. But again, I am seeing that with some creative use of the patient assistance programs, most people are getting the drug and they're getting it for the price that they can afford.
Right, yes, and there are foundations to contact to see about assistance with that also.
Is the drug screening warranted?
No. I find it deplorable. Don't get me started. We don't have enough time. It just really, really is wrong. But that's beside the point. They're doing it and they're getting away with it. And it's not the fight that's top of my list right now, but it's pretty high up there. It just bugs the heck out of me. That didn't sound very professional at all, but that's my opinion. It's my opinion.
Could someone clarify on the risk of transmission through sex?
Yeah. Do you want to try it, Ronnie or Robin?
I can talk about it. Sexual transmission is very low. Hepatitis C is not listed as sexually transmitted infection. We know that more studies need to be done in the area based on the studies that have been done in people in long-term monogamous heterosexual relationships. We know that sexual transmission is very low. We can't say that it's zero, but it's not the usual way that the virus is transmitted. There are some situations where the risk of transmission can be higher. That would be in the presence of certain sexually transmitted infections that can cause ulcerative situations. That can increase the possibility of the blood-to-blood transmission. If people who have multiple sex partners have higher transmission rates than people in long-term monogamous relationships, if sexual activity involves the blood-to-blood contact, and that can include some things like rough sex, dry sex, anal sex, sharing sex toys. This is, the standard information. We know there are higher rates of transmission in men who have sex with men who have HIV. I think that just about covers the sexual transmission part. I mean, anyone that's not in a long-term monogamous relationship like that needs to be practicing safer sex anyway, because there are other things that are more transmissible sexually than hepatitis C. Go ahead, Lucinda. I'm sorry. I think I cut you off.
No, I was going to cut you off. So I'm sorry. But I think that one thing is if there's, as Robin said, it's blood to blood. So if you're having sex with knives or chainsaws, you're in trouble. But other than that, it's really you've got to look at the individual practice. And if there's not a high risk for blood transmission, then there's probably not a high risk for hepatitis C transmission. So keep those chainsaws out of the bedroom.
What type of referrals are available for positive results from home test kits?
I think the same type of referrals that are results from others. I don't really know what a physician response is to a positive on a home test kit. I believe with those that you have a number that you talk to someone at the manufacturer, and I honestly have not gone through that process and don't know what documentation they provide you. That's actually a good question that I was just thinking of the other day. So that's my limited input on that. They may want you to repeat an antibody test, or they may be able to go to confirmatory for that based on the documentation available for you. But now I'm going to find out. We'll follow up on that. Anyone else have any more on that?
I don't know. I just don't know.
No, I don't either.
How can we share with our doctors information about the new treatments and protocols without offending them?
I would go to hepcguidelines.org and start printing out the information. We send that out to people that call on the helpline. There are different sets of information, different subsets in the guidelines that address the scenario. Have you treated before? Have you not treated before? Genotype and more. And we actually print out the appropriate part and send it to people so they can be educated and sit down with their doctor and show them that they're educating themselves, and can they review with them what their recommendations are.
And there are doctors that truly appreciate that.
There are, and if you can find that kind of medical provider, stick with him or her for life, because it's just really sad that a doctor would be offended
Exactly.
when a patient wants help.
Yeah.
How long can Hep C last on a toothbrush or razor, and what precautions can be taken to protect family members of an infected person?
Well, basically, those are theoretical routes of infection, and we really don't have data on it. We know that hepatitis C can live on a surface for up to 6 weeks, but whether that means that living on a razor and a toothbrush means that there's what the real threat for infection is, we don't really know. But I think it's just that we try to do our best, and try, if you have kids, tell them, and partners, tell people not to use your stuff. And in our house, we just kept things pretty separate so that I couldn't accidentally pick up my husband's toothbrush or vice versa. And it's just you just try to do the best, because we don't. If it was really very infectious, we would probably have a much higher rate than we do. But at the same time, that doesn't mean that we should turn our back on being cautious.
Combining a couple of other questions here, could somebody give further explanation about the mention of special populations, particularly African Americans or those with mental health issues? And also, are there any statistics on the rate of Hep C among college-age students?
We're seeing an increase on young adults between 15 and 30 the statistics are starting to come in because there's a lot of IV drug use going on in those communities.
The question about special populations, if you're referring to screening and incidence and prevalence, then these populations are highly underserved. But if you're looking at treatment, what we are now seeing that with the newer non-interferon-based treatments, and particularly if ribavirin is not used, that we may be less concerned, particularly with mental illness and ethnicity, because they seem to be easier to tolerate and they respond less, and they're not so sensitive to ethnic, to some of the DNA subtypes that were influencing the treatment outcomes that we saw with the interferon-based treatments.
And also, I think the person may be referring to some of the information on Bruce's slides for screening. We know there's a higher infection rate among African Americans in America. We know that among people who've been diagnosed with mental health diagnoses, that within some of those diagnostic groups, there's not a lot of data on it, but there are some studies that show some higher infection rates in some of those groups. I think one of the other things he mentioned was being incarcerated. We don't have firm numbers on that because the firm numbers would require effective surveillance, which is how we count, and counting incidents is part of that, and that's not really in place at this point. But we know that among people that are incarcerated, the rates are much higher than the less than 2% in the general population.
How long does it take fibrosis to go away once you are successfully treated, and how can pain around the liver be dealt with?
Could I have an easier question? This is Lucinda here. The problem, let me talk about the pain first. The problem with liver discomfort is that we don't know that not all pain and discomfort in the liver region is necessarily caused from hepatitis C. On the other hand, I know personally as well as professionally that we have a very high report rate of discomfort in the right upper quadrant. But sometimes it doesn't go away because it might have been caused by referred pain from the gallbladder or other causes. Second of all, as for dealing with it, it depends. If you're having severe pain, then that really needs to be medically addressed. If it's just minor discomfort, I don't know really what to suggest other than to ignore it, which is what I do. But I certainly wouldn't take anything for the level of discomfort that I had personally experienced. As for how long it will take, well, what we do know is that it takes up to 8 weeks for a partial liver transplant to fully regenerate into a fully functioning liver. Now, whether it will take that amount of time for fibrosis to dial back really depends on how much fibrosis there is and whether someone's drinking and all the factors. But some physicians say up to a year. And the truth of the matter is I've never seen any data on it.
We have someone who's looking for treatment for their husband with stage 4 cirrhosis, genotype 2, and had heart problems with Sovaldi ribavirin. He needs treatment without ribavirin, and doctors have told him to wait until next year. Any info?
Well, I do know that there's at least one drug that Bristol Myers Squibb put in an FDA application for a genotype 3 drug, and with any luck, with a combination of declazivir and Sovaldi. And with any luck, it might be able to be used off-label for genotype 2, because I don't think they asked for an indication for genotype 2. Now, I guess it depends on whether he has decompensated cirrhosis or cirrhosis, and whether he's been treated before or if this is a first-time treatment. But there's some indication that there might be a pan-genotypic medication that will be out in 2016. But I think if I had his situation, I don't know that I could wait. And I don't know if, again, I don't know enough about I don't know enough about what some of the alternatives are in the pipeline.
We have someone who works at a substance abuse facility, and they do a lot of referrals to local providers like the FQHC Health Department local hospital, and they want to know if you're saying that these patients will be denied treatment based on positive drug screens.
This is Lucinda again. Unfortunately, it's very highly likely they will be denied if their insurance company puts that requirement. Now, not all insurance companies are requiring that. Not all Medicaid programs are, but many of them are. But if they're in drug treatment and I mean, there are people that I think are doing amazing work in the harm reduction community that could probably answer this question better. People like Diana Silvestri in Oakland has had some remarkable results. So I would check with organizations such as OASIS and some of the community treaters who are working with active drug users.
Yeah, and we have 2 doctors in New York that are doing that as well.
That are doing what, Ronnie?
Oh, I'm sorry, working with active drug users, treating them. One is Dr. Brian Edlin, and the other one is Dr. Alan Litwin. Do we know where this person is?
I can find out after to follow up.
Okay.
And so we are getting close to 12:15. We have one last question I'll put out, which is what is Congress doing about the cost, but also this issue in general? And then I'll remind everyone that you can contact any of the panelists with additional questions by email, and that you all will receive a copy of these slides and a recording of the webinar, which will also be posted on our website.
Well, I'm so happy to have that question being asked. This is Lucinda here. There's an urgent alert that is being circulated by some of the advocacy organizations. NVHR has been a major player in this. And on Tina and I and Robin were all in D.C. this past week doing some lobbying for some support for funding for viral hepatitis programs. And on my blog at Hep Magazine, so if you just go to either put blogs.hepmag.com or in your search field put hepmag.com and look up the blogs, I have a step-by-step urgent request of everybody, and if this could be done today or first thing tomorrow morning, it might still do some good, and I just tell you exactly what we need. So thanks for asking that question.
And there are some ongoing efforts. You know, there'll be information on getting on the mailing list for urgent action alerts from NVHR. Another one that I encourage people to look at is the action alerts at hepcchallenge.org with the Caring Ambassadors programs. The legislators need to hear from us. They need to hear our stories. So you can get updates on specific things, but they need to hear our stories, and they need education, you know, not just on a federal level, but on a state level too. When they're approached about anything regarding viral hepatitis, the more they hear from their constituents and the impact it's having in their home state, home district, the greater impact it's going to have, and the better it's going to enable them to move forward in being supported in efforts for viral hepatitis.
Well, thanks, everyone. I think we're going to wrap up the webinar unless there's any final words from the panelists.
Well, thanks, everybody, for attending.
Absolutely. Thank you.
And thank you, Tina, for organizing.
Yeah, thank you all.